Okay, so I'll be giving you an overview of practice updates in lung cancer imaging guidelines and research. So we currently follow, as you are all aware, the 8th edition of TNM introduced by the International Association for the Study of Lung Cancer in 2016. And the same TNM descriptors are used for non-small cell as well as for small cell lung cancer, but the interpretation is a bit different. And the revised 9th edition is scheduled for 2024. So let's look at the key updates in the 8th edition as compared to the 7th edition. So there have been changes in the T and the M stage in the 8th edition, and the N stage remains the same. So there have been modifications to the T classification based on 1 centimeter increments in the tumor size. And in 8th edition, there has been grouping of lung cancers that result in partial or complete lung atelectasis or pneumonitis into T2 classifier. There have been grouping of tumors with involvement of a main bronchus irrespective of distance from the carina without the carina. Previously, the T stage differed based on the distance from the carina. Then the diaphragmatic invasion now in 8th edition is T4, whereas previously it was T3 because it has got a more ominous prognosis. And there has been elimination of the mediastinal pleural invasion from the T classification, because on imaging we really cannot differentiate a tumor which is involving the mediastinal pleura but not the surrounding structures from the ones which involves it. And there have been subdivision of the M classification into different descriptors based on the number and site of extrathoracic metastasis. For example, M1B is like a single extrathoracic mets, M1C is multiple, and so on. So there's also an entity called multiple ground glass or lipidic lesions. So it is known that adenocarcinomas in situ can present as multiple ground glass lesions. And in the TNM stage, we can, if we are suspecting such a lesion, we can give a T stage to it based on imaging as well, even if the pathology is not known, and we can upgrade based on the histopathology result. So the T stage in such case will be based on the size of the largest nodule, and in brackets we have to mention the number of nodules or M if it is innumerable. For small cell lung cancer, the TNM descriptors are the same, but we use limited and extensive stage while describing it. So stage 1 to 3, that is without any metastasis, any T or N stage, that can be safely treated with definitive RT, excluding the T3-4 due to multiple lung nodules which are too extensive or have a tumor nodal volume which is too large to be a single radiation plan. They are all grouped into limited stage, and the rest into extensive stage, those with metastasis. So now bronchoalveolar carcinoma is an obsolete term, it's no longer used. So that has given way to adenocarcinoma in situ, minimally invasive adenocarcinoma, lipidic predominant adenocarcinoma, and invasive mucinous adenocarcinoma have replaced this terminology. Now I need to mention over here that usually the lipidic, that is a non-invasive component, on imaging it appears as ground glass. Not always, but in most of the times, and the solid component is usually the invasive component. Now, coming to the imaging modalities for staging, the diagnostic modality is, of course, a CT with or without FDG PET for the T stage, and for N stage, again, the same modality. However, pathology confirmation is warranted when in case of a lymph nodal status. And for metastatic workup, of course, FDG PET CT and MRI brain in specific situations. In case of small cell lung cancer, combined small cell and non-small cell, the CCT thorax with abdomen and pelvis is recommended, and a PET CT should be performed if limited stage disease which is suspected. For MRI brain, that should be performed for stages 2, 3, and 4 of non-small cell lung cancer and limited stage of small cell lung cancer as I've specified, as per all the guidelines like NCCN, ESMO, ASCO. And NCCN also recommends that MRI brain should be performed for stage 1B if the tumor is large and centrally located. And then contrast enhanced MRI of the spine along with brachial plexus should be performed for superior sulcus lesions abutting spine, subclavian vessels, or the brachial plexus per se. And primary tumor or metastasis involving the vertebrae may sometimes need an MRI to rule out intraspinal extension or cord compression. And MRI thorax can serve as a problem-solving tool in case of indeterminate involvement of the pericardium, great vessel, heart on and CT. And in small cell lung cancer, MRI may be required for bone marrow imaging if PET CT is indeterminate. So coming to the limitations of the current TNM. The current 8th edition TNM does not address the issue of lymphangitic spread. So there is no separate T descriptor for that, although we assume that this is definitely a disease progression. Secondly, pleural invasion. Now, if we go through the TNM classification, the visceral pleural involvement is T2 and the parietal pleural involvement is T3, but on imaging we cannot differentiate. So I hope the next edition of TNM will address these issues. References, and thank you. Happy to take questions. No, so there's a difference. Multiple solid or ground glass. If it's a ground glass and we are suspecting they are in situ carcinoma, then we can give that kind of a descriptor. And if there are multiple lung nodules, then definitely it's metastatic. So the difference is in the attenuation. Thank you.